It is on my screen, so we're getting there. Yay! We got a presentation. It would be kind of funny if I were to sort of mimic all this without the PowerPoint. That would be interesting. Okay, so I will present our study entitled Individual Level Deviations from Normative Brain Morphology in Violence, Psychosis, and Psychopathy from my starting point as a clinician and a neuroimaging researcher. I have no disclosures. For decades, neuroimaging researchers have tried to map the anatomy of violence committed by persons with severe mental disorders. MRI studies from our group, which you can see a few of here, and others, have shown volumetric reductions of the orbitofrontal and the anterior cingulate cortex, the hippocampus, the amygdala, and hypothalamus, including their subfilter nuclei, as well as cortical folding and thickness abnormalities, and also brain age gaps associated with violence in psychosis. And this pattern aligns with regions and circuits involved in fear, reward, empathy, the processing of visual stimuli, and the formation of positive psychosis symptoms, including hallucinations and delusions. These findings vary across studies, which is expected considering the diversity of the violence and psychosis phenotypes. But the traditional neuroimaging research statistical methodology, comparing group averages, does not account for this heterogeneity. As such, putative individual brain deviations and patterns pointing towards distinct phenotypic neurobiological underpinnings might remain undiscovered. Moreover, not only do neuroimaging studies show great heterogeneity, the absurd associations to psychopathology are also subtle. And importantly, while most of the current research is conducted on the group level, clinicians and forensic experts must make decisions on the individual level. So, to supplement conventional group-based analysis and to address this heterogeneity, as many of you are well familiar with, statistical methods have been developed to model deviations from the norm on the individual level. The core concept of these models is based on pediatric growth charts as seen here, where individual variation is quantified against the growth information from a large reference population with mean values and percentiles. For instance, here or here. However, the same distance from the mean will be interpreted differently with age, as seen here from within the normal range and to an outlier that a doctor might be worried about. And this time perspective is lost in cross-sectional data where individual trajectories cannot be followed. So this concept has been translated into the neuroimaging field, where work by Markand and others have developed age-related norm charts for a range of brain regions, which provides an alternative to the classical case control or cluster analysis in neuroimaging research. With this approach, heterogeneous patterns of brain deviations have been mapped across mental disorders, but in different regions, where patients have unique patterns of deviations. So applying normative modeling to forensic psychiatry neuroimaging may overcome inherent challenges related to the small subject samples and serve as a powerful tool to investigate the underlying mechanisms. So the question is, do persons with a history of violence deviate from the norm in the same way or different? To explore this, we used data from the Norwegian ESTOP study, which is a Norwegian research project where data was collected as a collaboration between what was the Nordmenn Center for Mental Disorder Research, the SIFE Center for Forensic Psychiatry Research, and the Correctional Services, as well as the high-security psychiatry wards in 3 hospitals and the preventive detention department in 1 prison, all in the Oslo region in Norway. The project includes 4 groups of participants, that is, persons with psychosis and violence, psychosis and no violence, violence and no psychosis, and no psychosis, no violence, which underwent an extensive research protocol comprising a wide assessment of clinical presentations, self-report, and MRI protocol comprising T1, T2, DTI, resting site fMRI sequences. And where for our study, a history of violence was defined as having committed homicide, attempted homicide, or severe violence towards other persons. So for the present study, we included almost 1,400 participants, both men and women, where around 1,000 scans were used for training and calibration, and almost 400 included in the actual study. And as you see, there were all men, as you will see, there are all men in the actual studied group because there were almost no eligible women in the security wards and prisons. So the group of schizophrenia patients with a history of violence comprised 39 males with schizophrenia spectrum disorders and a history of severe violence from forensic psychiatry high security wards, with 196 persons with no psychosis or violence history representing the healthy control condition. They were randomly selected from the Norwegian National Population Registry. But to disentangle the psychosis and violence phenotypes, we included one group of participants with schizophrenia spectrum disorder, comprising 138 males from regular inpatient or outpatient wards, and one group of persons with a history of severe violence but no psychosis, comprising only 20 men, which is a small number, but it includes persons serving preventive detention, which is an indeterminate prison sentence enforced in cases where a time-limited sentence is deemed insufficient to protect the society. And this is the most severe penalty according to the Norwegian legislation and imposed in cases of exceptionally serious crimes. And we included almost 20% of the persons serving this sentence. And the small numbers in the severe violence groups do illustrate the challenge of conducting neuroimaging studies in these cohorts, especially in small countries with low crime rates such as our Norway. And we used T1-weighted images from a 3D scanner, and FreeSurfer was used to process data that passed control to control. And the ROIs we used to train the initial normative models determined the selection of parcellation atlases for cortical and subcortical regions. We used the pre-trained normative model developed by Rutherford Marquand et al., where models were trained using data of 58,000 individuals, 82 to 100 from 82 sites. Here exemplified for the left hippocampus, where the red lines mark the pre-trained the red lines mark the pre-trained norm values percentiles, and the dots represent the groups in our data, where data over or under 2 standard deviations are classified as extreme deviations. So, after we computed the negative and positive set scores, we performed the following analytical steps. To summarize the individual variation within each group, we computed the deviation scores into positive and negative deviations, and the percentage of subjects within each group with extreme positive and negative deviations at a given ROI were reported. Then we quantified the number of extreme deviations per individual to compare if participants from all diagnostic groups had a higher count of extreme deviations in general as compared to healthy controls. Subsequently, for completeness, we conducted case control group difference testing on the deviation scores across all ROIs. And finally, we correlated the regional deviation scores to clinical measures, and that is psychopathy scores in this presentation. So, yeah, here's just a quick overview of the clinical data stratified by groups. And the groups differed significantly on age, IQ score, and substance use, but not in alcohol use and current psychosis symptoms scores across the clinical groups, nor in psychopathy scores, that is the PCLR, for the violence groups. So what did we find? If we start with the negative deviations marked in pink, for the cortical area, the schizophrenia and violence group displayed extreme negative deviations in 2.6% of the cortical area regions. Individuals with schizophrenia without violence history and violent offenders without schizophrenia had on average a 3.1 rate, and healthy controls showed a 1.5% deviation rate. For the cortical thickness, negative deviations rates were less pronounced. And in the subcortical regions, persons with a history of violence with or without schizophrenia showed more pronounced negative deviations at 2.1 and 3% respectively, indicating a 3 to 5-fold increase as compared to the healthy controls, who had a rate of only 0.6%. And then for the extreme positive deviations marked in blue, the healthy controls presented rates of 1.5 in the cortical area and 1.6 in thickness and 1.2 in subcortical regions. Whereas the clinical groups generally had fewer positive deviations, except for the schizophrenia and violence groups rate of 2.1 in subcortical volumes. So overall, our results showed that All 3 diagnostic groups had high frequency of extreme negative deviations in area and volume compared to healthy controls, but not in cortical thickness. And the diagnostic groups had either fewer or similar instances of extreme positive deviations across all 3 modalities. And moreover, the graphs show number of deviations in percentages, that is the individual deviations. So where you can see here that the healthy controls in gray showed fewer negative deviations than the clinical groups. So if we look at the regional distribution of deviances across cortical measures, first the negative deviations. Well, all groups exhibit deviations in the prefrontal cortex. Both the schizophrenia violence and the schizophrenia non-violence additionally demonstrate notable negative deviations in regions of the occipital lobe. Within the schizophrenia violence group, the regions exhibiting the highest proportion of subjects with extreme negative deviations include the left anterior and the right posterior segments of the collateral transverse sulcus area, the medial area of the lingual gyrus, and the left occipitotemporal region. In the schizophrenia no violence group, the regions that were most associated with extreme negative deviations were found in the right hemisphere's parieto-occipital and suborbital sulcus area. And among the violent offenders without schizophrenia, the highest percentages of extreme negative deviations were noted in the left hemisphere's paracentral lobula and the sulcus and the middle frontal gyrus, impacting 20 and 15% of subjects respectively. Looking at positive deviations, we found more widespread deviations among healthy controls, but also to some extent in persons with a history of violence but no schizophrenia. And additionally, we extended our analysis to include not only extreme deviations, but also more subtle variations by contrasting each diagnostic group's deviation scores with the health controls. And at the strictest correctional level, that is for number of ROIs, contrasts, and imaging modalities, the schizophrenia and violence group had significantly higher mean Z-score values than healthy controls for negative deviations in the right subcallosal area. And when controlling for the number of ROIs and contrasts, but not the imaging modalities, also for the left medial occipitotemporal and lingual sulcus thickness. So these regions also differ between the schizophrenia violence and violent offenders without schizophrenia when corrected only for the number of ROIs, but not the contrast and imaging modalities. Looking at the subcortical values, we found that within the schizophrenia violence group, the region exhibiting the highest proportion of subjects with extreme negative deviations is the volume of the right cerebellar cortex. Looking at the pairwise comparisons, at the strictest correctional level, that is, again, for a number of ROIs, contrasts, and imaging modalities, in the schizophrenia no-violence group, we found significantly higher positive deviations in the volume of the left inferior lateral ventricle and in the pallidum volume when compared to healthy controls, where we know that enlarged ventricle volumes have for decades been associated with schizophrenia, and we also know that the volumes of the basal ganglia, which includes the pallidum, are affected by antipsychotic medication use. So we do not present the results from these studies as individual brain deviation maps of data protection reasons, and as an alternative, we will show the regional spatial distribution of negative deviations across the groups and modalities, where a given percentage has an extreme negative deviation in a given ROI. So first, here we see the regions where at least 10% of the sample have a deviation. Then the regions where at least 7.5% of the sample have extreme deviations. And finally, the regions where at least 5% have extreme negative deviations. And the pattern shows that both schizophrenia groups deviate in the prefrontal regions and visual cortex, the schizophrenia and violence group also in the cerebellum, but the violent offenders without schizophrenia only in prefrontal regions. And the controls shows almost no negative deviations. As I showed previously, the psychopathy scores obtained with the PCLR did not significantly differ between the violence groups. And we found no significant association between psychopathy scores and brain morphology deviations, but an overall heterogeneous pattern with predominantly positive associations, which were trend level significant for the area of the right subparietal sulcus and the thickness of the parieto-inferior supramarginal gyrus. And these are areas involved in interpretation of tactile sensory data, empathy, social cognition, and language comprehension. So, to sum up, these regions where persons with schizophrenia and violence deviated the most were regions within the collateral transverse sulcus and the lingual gyrus and the cerebellum. And what does this mean? Well, first of all, these regions do not overlap with the regions most often associated with violence and aggression in schizophrenia from previous case control-based studies, from our group, nor from others. That is amygdala, the hippocampus, the orbitofrontal cortex, and the anterior cingulate cortex. Secondly, the observed regions are all located in the basal temporal occipital lobes. They show heritable and sex-specific morphology and are involved in visual processing, including visual perception, object recognition, memory, and integration, but have also been associated with psychosis, violence, aggression independently. And the schizophrenia and violence group also showed more extreme deviations in the cerebellum. And we know that the cerebellum is important to motor control, cognition, and executive control, but has also been linked to aggressive behavior. And to follow up on this cerebellum finding, we have conducted a study using normative modeling of cerebellar subregions, which is under its final stages of peer review now. And we have also submitted an Enigma Antisocial proposal to explore this further. But taken together, the pattern of deviations in the schizophrenia and violence group, which was our main group of interest, point toward regions already known to be associated with violence, aggression, and social interaction, but also visual processes which have been linked to delusion formation and social cognitive performance. So, to conclude, our main findings were an overall heterogeneous pattern of deviations on the individual level, with a higher number of extreme negative deviations in violence and schizophrenia, which differed between clinical groups. And the study expands upon the observed patterns of regional group differences identified in traditional case control studies of violence and psychosis. So, with that, we have demonstrated how we can use normative modeling to map individual brain regions and the morphological heterogeneity in a forensic psychiatry population, which may also in the future be of use to provide clinicians with individual-level neurobiological information that, together with other clinical information, may inform treatment selection and targeted interventions at the individual level. And with that, I would like to thank the team, especially Jaroslav Rokitsky and Kristine Fristad and Thomas Wolfers, with a picture here of the entry to our old and protected, but still with a security ward hospital at Gaustad in Oslo. And thank you all.